Okay, we're there. Part 3, respiratory emergencies. Let's get busy. So scene size up. Not a lot of difference, right? Nearly every single time, it should always be the same. So we want to make sure we're using standard precautions and PPE. We also want to consider the possibility of infectious diseases or toxic substances. Those things affect things for us. So mechanism of injury or nature of illness, if we're talking about a respiratory emergency, more than likely we're talking about nature of illness, but it could be secondary to a trauma. So if in question, ask why we're there. Ask why 911 was activated. So question a patient, family, bystanders. I want to question everybody to find out about the nature of illness, of what's going on. Identify immediate life threats, big time primary assessment. We want to make sure we are able to reverse anything that puts our patient at an immediate life threat risk. Form a general impression, so age and position of the patient. Overall, we want to think about their distress, at their patient's level of distress, age and position of our patient. Calm or anxious, we would definitely want to get their LOC, so AVPU. We want to ask about their chief complaint. Airway and breathing, we want to make sure the airway is patent and adequate, right? When we ask them what they called for, what's going on, if they give us a good full, couple sentence answer, we're probably pretty good. If there is any question though about airway patency, must be opened immediately using a head tilt, chin lift maneuver, or if it's a trauma, obviously a jaw thrust maneuver, modified jaw thrust. So we want to evaluate whether that patient is breathing adequate, right? How do we do that? Rate, rhythm, quality, all of those things. Ask yourself the following questions when you're thinking about this. Is air going in? Is air going out? Does the chest rise and fall with each breath? Is the rate adequate for the victim's age? So those are kind of just a quick little shot, quick little approach to that. Assess breath sounds. So check your breath sounds on the right and left sides of the chest. We want to make sure they're equal. We want to listen over the bare chest. Hopefully that's an option. If not, then we're going to have to listen through some clothing, but try to get under someone's shirt. We want to determine whether breath sounds are normal. Right? So you may see in your book vesicular breath sounds or bronchial breath sounds. Take a look at that. Or are they decreased or absent or abnormal? What did we say earlier abnormal breath sounds were going to be? Yep, adventitious. So we're looking for adventitious breath sounds. So check breath sounds on the right and the left of the chest and compare. Listen to breath sounds for a full respiratory cycle. Now, abnormal sounds include snoring, wheezing, crackles, rhonchi, stridor. Those are all adventitious breath sounds. Now we've done A, B. Now we're moving on to C. So we want to evaluate for shock and bleeding. Is that an option? Are they shocky or are they bleeding? Do we see gross bleeding? We want to assess capillary refill in infants and children and assess perfusion by evaluating skin color, temp, and condition, right? We know because we're shock experts now that the skin is one of the first organs that start to see some differences in shock. So we want to reassess and identify any life threats in our patients. And any of these kind of things would be included in our following signs and symptoms. So problems with ABC, poor initial general impression, unresponsiveness, potential hypoperfusion or shock, chest pain associated with a low blood pressure, severe pain anywhere, and then excessive bleeding. These are all things that we need to identify that, if this is going on, we've got a problem. Now we get to our transport decision. We want to think about where they need to go and how do they need to go there. So we're looking for if there's a unstable or a life threat condition. We want to address the life threat. We want to proceed with the rapid transport. History, objective and subjective observations are important in building a general assessment. So you want to make sure that you're reporting pertinent negatives. So when we talk about, like, say someone fell, but they didn't get knocked out. That's a pertinent negative. Patient fell, but denies loss of consciousness. Those kinds of things. Different respiratory complaints offer different clues and different challenges. So, one thing we want to do is determine the patient's baseline status for sure. And then we have something to go off of. Now, with patients in respiratory distress, A sample history can be collected from the bystander or the family or even the patient if they can speak. So make sure you ask the following about a patient in respiratory distress. What's the patient's general state of health? You know, maybe they're a bad COPD patient. Has the patient had any adult diseases, or if it's a childhood diseases? Has there been any recent surgical procedures or hospitalizations? And then has there been any traumatic injuries? Now, OPQRST can be modified to gather some information about the breathing problem. So when did the breathing problem begin? That's kind of the same thing as onset, right? What makes the breathing difficulty worse or better? Same thing as provocation or palliation. So how does the breathing feel? Quality. How does the discomfort located and does it move? Radiation and region. How much of a problem is the patient having? So severity. You know, it's a really big problem. Well, we need to do something about that. So is the problem continuous or intermittent? If it's intermittent, how frequently does it occur and how long does it last? And that goes on down to our T for timing. So the PACE assessment is an alternative assessment for a complaint of shortness of breath or difficulty breathing. We hit a lot of the same things, but not everything. So progression, how has it progressed? Associated chest pain, is there any? Sputum, yes or no? Talking tiredness, are they able to speak in sentences and get tired? Exercise tolerance, are they able to get up and move without, you know, becoming short of breath and not able to continue on. So the secondary assessment, a little bit more in-depth assessment of body systems. So we only want to proceed with secondary assessment if the life threats have been addressed and treated as always. So make sure you keep an open mind, you know, gather as much complete history as possible and perform a secondary assessment. When we do that, we're looking at, we know, respiratory, cardiovascular, skin, blood pressure, neurologic. Now, if you do have some monitoring devices, if you're a service that has that, you want to go ahead and do that. Make sure you're getting some vital signs and what their O2 saturation is and all of that. Now, look for signs of COPD. So usually you get some kind of, I wouldn't call them telltale signs, but you see this is common. So patients usually older than 50, they have a history of lung problems, almost always long-term active or former cigarette smokers, complain of tightness in their chest, may have a barrel-like appearance, their chest, often use accessory muscles to breathe, and exhibit abnormal breath sounds. Now here is something I added. So we see emphysema or barrel chest. You see the difference. So we see that this is a normal adult shape, and this is that barrel shape. So it's much more like a barrel, you know, more like a 55-gallon drum, and it causes some real problems for them. Reassessment. Repeat the primary assessment. So we want to determine if there have been any changes in their condition. You know, we want to confirm the adequacy of interventions and patient status if we've done something. If the patient's condition is stable and no life threats, we know that we can continue on at every 15 minutes. Now, thinking about what we can or can't do intervention-wise, you know, for respiratory problems, we might see some things like providing some oxygen via non-rebreathing mask at 15 liters a minute. Providing positive pressure ventilations using an ambu bag or a BVM, using airway management techniques such as an OPA or an NPA. We may do some suctioning. We may do some airway positioning. A lot of different things we can do. Providing non-invasive ventilatory support with continuous positive airway pressure. So that says a lot. What we're talking about is applying CPAP to that patient. Okay. Positioning the patient in a high Fowler's position or position of choice, assist them with some respiratory meds. Then, of course, we need to move all this information onto the receiving hospital. So emergency medical care, what are we going to do? What can we do? So if a patient complains of difficulty breathing, we should be administering some supplemental O2. Some patients may need CPAP or even ventilator support with a BVM. So take good care in monitoring respirations. We really want to pay attention to that. We want to reevaluate respirations for a sick person at every 5 minutes. We do not want to withhold oxygen in patients with COPD. Don't take that hypoxic drive thing, you know, to task and say, well, I can't give them oxygen because of this. That's something you need to be aware of. But somebody that is hypoxic, we always give them oxygen. And they might have a metered dose inhaler or small volume nebulizer. You know, that might be something that you're able to help them with. Consult your medical control and make sure the medication is indicated. Ensure there are no contraindications to the patient's condition. So the patient's unable to help coordinate inhalation. The MDI or metered dose inhaler or small volume nebulizer is not prescribed to the patient. We're not going to do that. These are all contraindications. You did not obtain permission from medical control. Medication is not permissible by local protocols. The patient's already met the maximum prescribed dose. The medication's expired, or even there's other contraindications specific to the medicine. Now, within these medications, respiratory inhalation medications, they are mostly used to relax the muscles that surround the air passages in the lungs. So essentially what we're talking about is dilation of those airways, right? Now, common side effects can be increased pulse rate because of, I don't want to get into it because of the way these medications work. You can certainly have an increased pulse rate. It can cause some muscle tremors. It can cause some nervousness. Medication from an inhaler is delivered through the respiratory tract to the lungs, and we'll be going over these skills. Upper or lower airway infection. So humidified O2. Now, don't attempt to suction the airway or place an OPA in a patient with suspected epiglottitis. We talked about that. Make sure we position them comfortably, transport promptly. Acute pulmonary edema, we're going to put some O2 on them. We're going to suction if necessary. We want to position them comfortably in a position of comfort. Now, an unconscious patient may require full ventilatory support. So you may need to put in an airway adjunct and ventilate them. But you can also put on some continuous positive airway pressure for these guys if it's indicated and allowed by protocol. Regardless, we want to transport promptly. But for acute pulmonary edema, what we're seeing here, the biggest thing is going to make a big difference is that CPAP if you're allowed to use it. Chronic obstructive pulmonary disease, COPD. So we can assist with that prescribed inhaler. You want to make sure to watch for the side effects due to overuse. Definitely want to position them in comfortable position as well as transport them promptly. Asthma, what are we going to do for that? Well, we're going to determine if asthma is really their problem. You want to be prepared for suctioning. You want to assist the asthma patient with that prescribed inhaler. Provide aggressive airway management, oxygen, and prompt transport. So one thing to think about, a prolonged asthma attack that's unrelieved, that can progress into a condition known as status asthmaticus. This is a true emergency. So we want to be able to get something done with their asthma attack. Hay fever, not going to do much about that. Anaphylaxis, remove the offending agent. Maybe it's a stinger or who knows what it is. Maintain the airway, transport rapidly, and then depending upon your protocols, administer epinephrine if you can. Spontaneous pneumo, not much we can do for that, or pleural effusion. You want to go ahead and give them some O2 and transport promptly, and then you want to make sure that you're monitoring. Obstruction of airway, so provide supplemental O2 and transport. Now, if that's a partial airway obstruction, if it's a complete, you want to clear the obstruction and administer O2, and then transport, of course. Pulmonary embolism, not much we can do about a blood clot, right, in the pulmonary circulation. So supplemental O2 is mandatory, position comfortably. Now, if hemoptysis is present, if they're bleeding, in their airway, we want to make sure that we clear the airway immediately and then transport promptly. So hyperventilation, complete primary assessment, don't have them breathe into a paper bag. We mentioned that. Reassure the patient, provide supplemental O2, and transport promptly. So environmental, industrial exposure, ensure that these patients are decontaminated, give them some O2 and adjunct if necessary, suction if you have to. Foreign body airway aspiration, lots and lots of stuff, guys. I know we're just nailing a whole bunch here, but we're talking about the treatment of these specific conditions. So we're kind of having to hit every one of them just kind of hard and fast. So foreign body aspiration, clear the airway, O2 transport. Tracheostomy dysfunction, positions comfortably. Suction to clear the obstruction if you're able to, and then provide some O2 as well. Asthma, provide blow-by oxygen. Use your metered dose inhaler if they're able to provide one. As with chronic disease, asthma may be life-threatening in an older patient. There's not much to do about cystic fibrosis. It's a genetic disorder that affects the lungs and the digestive system. So, once again, we're going to oxygenate as needed, suction when we can, and call it a day. Okay, that is part 3. Thank goodness we made it. You guys didn't know if we were going to make it. I could tell, but we did. So, have a good day.